Welcome back to the session on carcinoma esophagus. What is the etiology? What are all the clinical features? How to investigate the case and how to treat the case we will come to. Now, describe carcinoma esophagus and its management also. First, we are going to look at the types of the carcinoma esophagus. It is two types. One is squamous cell cancer and the other is adenocarcinoma of the esophagus. So, one has to be the squamous cell cancer and the other thing has to be the adenocarcinoma of the esophagus. When I am talking about the adenocarcinoma of the esophagus, it is usually seen in the lower one third of the esophagus, whereas squamous cell cancer is seen in middle one third of the esophagus and maybe seen in the upper one third also, but adeno mostly it is seen in the lower one third only. Coming to what are all the factors, etiology, what are all the risk factors which are causing this? Write it down. Not etiology, you can write it as a risk factors. Okay. Smoking, alcohol, corrosive stricture, Plummer-Vinson syndrome, where you can see the esophageal webs, iron deficiency, anemia, all those things. Plummer-Vinson syndrome. Okay. Tylosis. What do you mean by tylosis? Hyperkeratosis of the palms and soles is called as tylosis. Now, infection with the human papilloma virus, even achalasia cardia, we will discuss this in a different module. Write it down, achalasia cardia. And even some of the dietary factors such as nitrosamine rich foods when you take, it may cause the esophageal cancer. Okay, smoking, alcohol, corrosive stricture, okay, Plummer-Vinson syndrome, tylosis, infection, human papilloma virus infection, achalasia cardia. Okay, all these are the risk factors. Some other risk factors, especially for the adenocarcinoma, we are discussing right now. Now, adenocarcinoma, what are all the risk factors? What we have all seen, smoking, alcohol, corrosive, all these are mainly for the squamous cell cancer. But for adenocarcinoma, three important risk factors you have to remember. One, obesity. Two, GERD. Three, Barrett's esophagus. These are the three important risk factors for adenocarcinoma: obesity, GERD, Barrett's esophagus. Okay. Even I want to tell you there is a protective factor also. H. pylori infection is something which is protective for adenocarcinoma of the esophagus. Write it down. It is protective for adenocarcinoma of the esophagus. Risk factors, what are the risk factors for adeno? Obesity, GERD and Barrett's esophagus. If you see this, obesity and GERD, there in Western countries there is an entity of obesity and GERD is always there. That is why in Western countries, adenocarcinoma is, the cases of adenocarcinoma are increasing. Okay, whereas in other countries it is mostly squamous cell cancer, but whereas in Western countries most common is adenocarcinoma. Nowadays even the trends of adenocarcinoma are going to increase. Why? Because due to obesity and GERD, all these things. Okay. Coming to clinical features with which a patient of carcinoma esophagus is going to present to us. You already know the age group. It is almost an elderly age group, okay? More than 60 years age of presentation. So with what is the symptom the patient is going to present to us? It is all about dysphagia. Okay. Sir, you can you elaborate the dysphagia? Yes, it is a first thing, it is a progressive dysphagia. It is a progressive dysphagia. Second thing is dysphagia is mainly for solids. Okay, if at all the dysphagia is mainly for liquids, and the age of presentation is also on the younger age group, think in terms of achalasia cardia. Okay, when the age of presentation is more and dysphagia is mainly for solids, think in terms of the cancer. Okay, just a second. Okay, dysphagia in cancer esophagus is always a progressive dysphagia, and the dysphagia is mainly for solids. Maybe it may be solids plus liquids also, but it is mainly for solids. Now I am telling you dysphagia. Will the patient be going to present to us immediately when he has cancer? No. Even dysphagia itself is a late symptom. Okay, mostly the patient with cancer esophagus is going to present to us in a advanced state. Only in advanced state only we can see dysphagia also. That is when the patient is going to present to us. So as the patient is going to present to us in an advanced state, what is the prognosis? Definitely a poor prognosis. Now there may be an entity of regurgitation of food can also be there. Now tell me other features of a cancer. Yes, weight loss will be there. So write it down. Loss of appetite, loss of weight. Okay, these things can be seen. And due to chronic blood loss, even there can be iron deficiency anemia in this patient also. Iron deficiency anemia due to chronic blood loss. Okay, now this carcinoma esophagus is capable of infiltrating into the adjacent tissues. Okay, what happens when the adjacent structures are involved, we will come to know. It can infiltrate adjacent organs. It can involve, so what are all the adjacent organs? It can involve the trachea, it can involve the bronchi, it can involve the aorta. Okay, suppose it is involving trachea and bronchi, airway. Okay, what may be the symptoms we can see? There can be hemoptysis. Okay, it can even lead to the obstruction within the airway. Airway obstruction can happen, and there can be a possibility of fistula formation between the esophagus and the maybe trachea or maybe bronchi. Okay, esophagus and the trachea there may be fistula, or esophagus and the bronchi there can be formation of a fistula also. Write it down. There can be formation of a fistula between what? Esophagus and the airway. Okay, and what might be the other structure which can be involved? Even aorta can be involved. Okay, one is trachea and bronchi and the other is aorta. These things can be involved. Now coming to spread. If you ask me locally how it is going to spread, if you take the esophagus, the submucosa, within the level of the submucosa, there are many lymphatics. Okay, the submucosa of esophagus is very rich in lymphatics. That is the reason why it is going to spread longitudinally along the submucosa. Okay, write it down. Longitudinal submucosal spread will be there. Why this is happening? Why? Because esophageal wall, that is within the submucosa, has a rich network of lymphatics, right? Lymphatics rich. So what can even happen? There can be metastasis to the lymph nodes also. We can see the lymph node metastasis. Even we can see the distant metastasis also. Why distant metastasis is occurring? Due to hematogenous spread. So what might be the sites? As usual, it can involve the liver, it can involve the lungs. Okay, or any other distant metastasis is possible. Now, I have already told you the clinical feature. I mean, the age of presentation is around 60 years or more. The patient is going to present to us with dysphagia. It is a progressive dysphagia. The dysphagia is mainly for solids. Okay. Now, it can even present with iron deficiency anemia due to chronic blood loss. It may present to us when it has been infiltrated into trachea or bronchi. Hemoptysis we can see. Even there can be airway obstruction, there can be fistula formation, all those. It can involve the aorta also. Now, there can be lymph node metastasis. There can be distant metastasis to the liver and lungs due to hematogenous spread. As the esophageal wall within the submucosa, there are many lymphatics. There is always a longitudinal submucosal spread is there in case of cancer esophagus. With all these things in mind, now we are going to look at it. Now, even as it is a cancer, you can see weight loss, you can see loss of appetite and all those things you can write. Now, coming to, I have already told you dysphagia is always a late symptom. So the patient is going to present to us in an advanced state. Now the question is, can we detect this? Can we detect this in an early stage? The answer is yes. So how to detect? So if at all early cancers, okay, there is just a second, yes, chromoendoscopy. Endoscopy you already know. Chromoendoscopy. Chroma means what? Different colors can be seen. Now, chromoendoscopy, we are doing this using Lugol's iodine. Chromoendoscopy with the Lugol's iodine. Now, what it is going to show us? If it is appearing brown in color, then it is normal squamous mucosa of the esophagus. Okay, if it is appearing brown, then that's perfectly okay, it's fine. But by chance the tissue is unstained, any tissue which is unstained, you have to think in terms of a cancer. Okay, you have to think in terms of a cancer. Normal squamous mucosa is something which is brown in color. If at all it is unstained, then you have to think in terms of a cancer. Right. This is what I am telling you for early cases. If you want to diagnose these early cases, then you have to use chromoendoscopy with Lugol's iodine. Okay, now coming to the advanced cancers, I can get a barium study done, barium contrast study. What we may see in the barium study, we can see some ulcerated one, or we can see a stenotic lesion with the proximal dilatation. We are going to see. Okay, proximal to the cancer there will be dilatation. Why? Because this cancer is causing something like a obstruction to the lumen. Okay, that is why there will be proximal dilatation. We can see ulceration, or we can see a stenotic lesion with a proximal dilatation on barium contrast study. Now we can do endoscopy, we can even do chroma endoscopy. That's a different. On endoscopy itself we can visualize the tumor. Okay, if we perform an endoscopy, we can directly see the tumor, and even with this we can get a biopsy of the tumor also. With the endoscopy we can even get the biopsy of the tumor also, we can get. Coming to what are all the investigations I have to perform in a case of cancer esophagus. First thing, I am going to get a hemoglobin, and obviously basic investigation only. Even I have already told you, due to chronic blood loss there is always an entity of iron deficiency anemia also in this patient. Okay, that is why better to get a hemoglobin levels done. Now liver may be involved due to distant metastasis, hematogenous spread. Liver may be involved. I have to get a liver function test done. I have to get a ultrasound done. Even ultrasound may also show me the metastasis into the liver and all. Okay, barium swallow. Barium swallow is very important because this is the one which is making us to diagnose. We have already seen what are all the findings on barium contrast study. Endoscopy, I can visualize the tumor and I can even get a biopsy of the specimen also. Chromoendoscopy, especially for detecting the early cancers, chromoendoscopy is very useful. Okay, now I can do other investigations, like I can get a chest x-ray, I can done bronchoscopy. Can you tell why bronchoscopy is useful? I have already told you, there it is going to infiltrate trachea and bronchi. Okay, even if there is any fistula formation between the esophagus and the bronchi, you can easily identify that under bronchoscopy. Now, I have to get a endoscopic ultrasound. Okay, I have to get a CT scan and I have to get a PET scan. All these things are necessary. Endoscopic ultrasound, CT and PET, all of them are necessary for staging the esophageal cancer. One point I want to emphasize here, I am getting CT scan, I am going to get a PET scan, that's okay. Endoscopic ultrasound, especially, what is the main use if you ask me? To know the depth, how much depth it has been involved. Depth of wall involvement is best assessed on a endoscopic ultrasound, very important. Okay, depth of invasion of a esophageal cancer is best assessed on a endoscopic ultrasound. Other investigations, I can get a thoracoscopy, I can get a laparoscopy. Why these things are also important? Because if there is any lymph node metastasis is there, or if there is any distant metastasis is there, I can directly visualize these things. Okay, that is why these are thoracoscopy and laparoscopy are also important. Now coming to staging. Staging I am not going into very much detail, but I am going to explain you how it is going to work. It is divided into T1, T2, T3 and T4. T staging I am dealing with you. T1, if you ask me, it is 1A and 1B. If it is involving the mucosa, it is 1A. If it is involving the submucosa, it is 1B. If it is involving the muscle, it is T2. If it is involving adventitia or involving the serosa, it has to be T3. If at all it is involving the adjacent structures, then it has to be T4. If it is involving mucosa, it is T1A. Submucosa, it is T1B. Involving the muscle, it has to be T2. Involving the adventitia or serosa, it has to be T3. Involving the adjacent structures has to be T4. Mucosa, submucosa are T1. Muscle is T2. Adventitia or serosa is T3. What is T4? Adjacent structures being involved has to be T4. Now, I am going to discuss the treatment overall here. Okay, for if it is involving mucosa or if it is involving submucosa, I can get a surgery done. What is the surgery we will come to next, but we can get a surgery. If it is involving the muscle, involving the adventitia or serosa, or even it is involving the lymph nodes. Which lymph nodes? Left gastric, short gastric, mediastinal and paratracheal. If at all there is involvement of these lymph nodes. Okay. Now first thing I have to do is I have to give chemotherapy. Neoadjuvant chemo. Whenever I am giving chemotherapy before surgery, I have to call it as a neoadjuvant chemo. After which I have to do surgery. Followed by that again I have to give chemotherapy. Okay. Sir, what chemotherapy you are going to give? I am going to give ECF. Epirubicin, cisplatin and 5-fluorouracil. This ECF is the chemotherapy I am going to give. By chance there is adjacent structure involvement, or if it is there is a distant metastasis, or I have mentioned 4 lymph nodes here: left gastric, short gastric, mediastinal and paratracheal. If other than these any major lymph nodes are involved, then I have to consider it under other lymph nodes. Okay. Then even I should not get the surgery. This is already an advanced one. Means I have to do some symptomatic treatment or some palliative treatment. If at all there is the patient complaining is of dysphagia, I have to insert self-expandable metallic stent. Okay. So this is your self-expandable metallic stent. This is stent I have to insert into the esophagus so that it remains like a tunnel and the patient is gonna get relieved from the dysphagia. Okay, self-expandable metallic stent. If the patient complains of pain, I have to give radiotherapy. Like these things I have to do, just a palliative measure. If at all there is dysphagia, I have to keep self-expandable metallic stent. If at all the patient complains of pain, I have to provide him radiotherapy. So far what we have seen here is okay. If it is involving the mucosa and submucosa, we have to do surgery. If it is involving the adventitia or serosa, or it is involving the lymph nodes like left gastric, short gastric, mediastinal and paratracheal, okay, or it is involving the muscle, all these places what we have to do, first thing is, even before surgery we have to give chemotherapy called as neoadjuvant chemo. After that we have to do surgery. After surgery we have to give chemotherapy again. What is the regimen? ECF, epirubicin, cisplatin, 5-fluorouracil. What if it is involving the adjacent structures, or distant metastasis is there, or lymph nodes other than, major lymph nodes other than the above forementioned are involved? There is nothing much I can do. I have to do only some palliative treatment. If at all there is dysphagia, I have to keep a self-expandable metallic stent. If at all there is a pain, I have to provide radiotherapy. This is the how we are going to treat. Now, I have told you for mucosa and submucosa I have to do surgery. Even for the other things, first I have to give neoadjuvant chemo followed by that surgery. So, what is this surgery? This surgery I am going to elaborate now. Okay. So, first thing is, I am dividing this into two. One is intrathoracic esophageal cancer and the other is cervical esophageal cancer. If it is in the cervical part of the esophagus, okay, then I am doing it there. First I will discuss about the intrathoracic cancer of the esophagus. Write it down. Intrathoracic esophageal cancer treatment. So what is the surgery? Suppose this is your esophagus. Somewhere here there is a tumor. Proximally I have to take a margin. Distally I have to take a margin, and I have to excise all these things. Okay. I have to do wide excision. Proximally I have to take 10 centimeter margin, and distally I have to take a 5 centimeter margin, and I have to excise the tumor part and the surrounding part. Along with that I have to remove the lymph nodes. Which lymph nodes? I have already told you the 4 lymph nodes. Okay. Left gastric, short gastric, mediastinal and paratracheal lymph nodes I have to remove. I am calling this as radical. Radical because I am not only removing the tumor, some part above and below the tumor, and also I am going to remove the regional lymph nodes also. That is why radical esophagectomy I can call. I can get this surgery done maybe through the transhiatal route, or maybe through transthoracic route. Okay. Now here you have to remember few names of the surgeries. Okay. Under transhiatal you have to remember Ohringer's transhiatal esophagectomy. In transthoracic there are two entities. One is Ivor-Lewis is one technique, and the other technique is Mecnion technique. Without any doubt, the best surgery among these three things is Mecnion. Now, we will look what we are going to do in these things. One is transhiatal and the other is transthoracic. Within transhiatal, it is Ohringer. Within transthoracic, it is two, Ivor-Lewis and Mecnion. Now, let us suppose. So, I am somewhat poor at drawing. Please understand that. Just the schematic one I am drawing. This is the neck part and this is your thoracic part. So in Oringer, what I am going to do is I have to give a midline incision also. Not only that, I have to give another incision here at the around at the sternocleidomastoid muscle is there, no, at that level I have to give another incision and I have to open there also. Whereas coming to Ivor Lewis, in Ivor Lewis, what I am doing here is first I am going to give a vertical midline incision here also. First I am going to give a vertical midline incision. I am going to mobilize the stomach here. Okay, so that it can be mobilized freely up. Okay, I am going to mobilize the stomach, after which I am going to close this incision. After closing this incision, what I am going to do is again I am giving another incision in the 6th intercostal space around. I am going to give another incision around in the 6th intercostal space. Firstly, what I have done, vertical midline incision. I am going to free the stomach, mobilize the stomach. I am going to close the incision what I have given. Now I will make the patient in a left lateral position. In the left lateral position. After that, I am going to incise where? In the 6th intercostal space. I am going to perform thoracotomy. I am going to open the thoracic cavity. In the 6th intercostal space, I have given an incision and I have done thoracotomy. Now, what I have to do? I have to do radical esophagectomy now. Okay. But what happens in Mecnion is, I am opening this midline. That's fine. Not only that, I am doing thoracotomy here at this level also, similar to Ivor Lewis. Not only that, I am going to incise in the neck region also, in the cervical region also. I am going to give an incision in the Mecnion. Okay. In Oringer, I am going to give only 2 incisions. One is the vertical midline incision and the other is in the neck. Whereas in case of Ivor Lewis, again I am going to give only 2 incisions. One is in the vertical midline and the other is I am going to do in the thoracic cavity. Thoracotomy I am going to perform in the 6th intercostal space. Whereas in Mecnion, I am giving 3 incisions, very important. I am giving 3 incisions, vertical midline, even a thoracotomy incision and even an incision in the neck also for the cervical part. Whether in Oringer, whether in Ivor Lewis or whether in Mecnion, in all these 3 things, I am removing some part of the esophagus and I am anastomosing the esophagus part with the stomach. So what is the replacement of choice in all these 3? It is stomach. Okay. Whereas in Oringer, the anastomosis is between cervical esophagus and the stomach. Whereas in case of Ivor Lewis, it is between the esophagus and the stomach. In case of Mecnion, again it is cervical esophagus and the stomach. Okay. Now, pulmonary complications are less likely in case of Oringer. Why? Because pulmonary complications are less in Oringer. Why? Because we opening the chest? No, we are not going to open the chest in Oringer. Whereas in Ivor Lewis and in Mecnion, we are going to open the chest. But in case of this, we are not opening the chest. As the chest is not opened in case of Oringer, the pulmonary complications are less. Whereas here you can get pulmonary complications, here also you can get the pulmonary complications. Okay. In all these 3 things, there is anastomosis between the esophagus and the stomach. So there is always a possibility of anastomotic leak. Anastomotic leak can happen in all these 3 things. Okay. Coming to local recurrence. If you look at the Oringer, Ivor Lewis and Mecnion, if you take Ivor Lewis, we are going, the part which we are removing is very less in case of Ivor Lewis. Why? Because we are not opening it till the neck. We are just opening in the middle. Okay. That is why when we are opening only in the thorax, we are not opening the neck. So we are not removing the esophagus till the cervical esophagus level. That is the reason why local recurrence is a possibility. Why? Because we are not removing very much length of the esophagus. That is why local recurrence is more seen in Iberluis. And one thing I want to tell here in Mecnion is something which is a en bloc resection. We are removing everything. So we are removing the lymph nodes which are present in the neck region, which are present in the thoracic region, okay, and which are there in the abdomen region also. As we are opening all the three, we are opening in the neck, we are opening in the thorax, and we are opening in the abdomen. That's why all the three regions lymph nodes we are removing. Okay. Next, coming to what is the most common cause of mortality in this patient? It is nothing but your anastomotic leak. The moment there is the leak, anastomotic leak, what happens? There is a possibility of mediastinitis. Okay, this anastomotic leak can lead to mediastinitis. This is the most common cause of mortality in this patient. I have already told you what is the replacement of choice. I mean, we are removing certain portion of the esophagus, right? Now, how to replace that esophagus? We are pulling the stomach part upside. So, stomach is the replacement of choice. Now, what is the most important blood vessel? Most important blood vessel. Whenever you are doing this replacement with stomach, what is the most important blood vessel? It is right gastroepiploic artery. Right gastroepiploic artery is the most important blood vessel. So far we have discussed various things under intrathoracic esophageal cancer. Now coming to cervical esophageal cancer. Here also I have to do surgery. I have to remove pharynx, I have to remove larynx, and I have to remove the esophagus. Obviously only some part of esophagus. So not only that, I am going to remove pharynx and larynx also in case of cervical esophageal cancer. Again, replacement of choice, nothing but the gastric pull-up only. Now, I am going to pull the stomach up and I have to anastomose this stomach. Anastomose to what I am going to anastomose this? I have already removed the esophagus. Now I have to anastomose this to the neopharynx. Okay, I have to anastomose to the neopharynx. Instead of removing all these pharynx, larynx and esophagus, there is an alternative option for cervical esophageal cancer, that is chemoradiation. Okay, chemoradiotherapy is an alternative which is coming up. Instead of removing pharynx and larynx and esophagus, we can go for this chemoradiation also. Okay, thank you for watching.